Morning, everybody. I think we have a really good panel lined up and a very good-looking panel as well. You just got sort of a mini master's degree in adult stem cells. We want to dive into some more of the details, talk about, it was very promising what you just heard from Dr. Alt. We want to expand on that a little bit, but also be very responsible and realistic about what these stem cells have to offer. I didn't know they could possibly treat baldness, for example, so I'm intrigued now. But mesenchymal stem cells in particular are something that we're going to focus on. You've seen a lot of headlines about these. You obviously just heard this talk. Some of the headlines about mesenchymal stem cells have talked about the fact that they could be used to replace certain organs, maybe even making the field of transplantation less important in years to come. You may not have to check that box in your driver's license anymore in the future. But where exactly do all these stem cells live? We hear they're in every organ in the body. What do they do there? What are their natural purposes there? When you remove these stem cells from their natural reservoir, how do they change? What does it mean for the tissue that you removed it from? What does it mean for the tissue in which you're injecting it? We want to talk about a lot of those issues. To explore this, we're going to hear some presentations from our panel. Going to have some questions and answers afterward. So let me just briefly introduce everybody, and then we'll get started. Dr. Philip Schoettle, Dr. Philip Schoettle over there, Medical Director of Orthopedics and Sports Medicine at Isar Klinikum. Marilyn Glassberg over here, Professor of Medicine and Surgery at the University of Miami Miller School of Medicine. Donna Scarrett, CMO, Mesoblast, you heard from her a couple of days ago. They are a global leader in the field of regenerative medicine. Eduardo Bravo, CEO of TiGenix, going to be talking about the treatment of fistulas and Crohn's disease using stem cells. And last but not least, Dr. Mohit, Khera, Associate Professor of Urology at Baylor School of Medicine, is going to be talking about mesenchymal cells for erectile dysfunction as well. Presumably it lasts longer than 4 hours, is my guess. Dr. Schoettle, let's start with you. Sorry.
Well, thank you. Starting here with a nice example of an animal which we treated which has been treated by stem cells, and animals can't tell you a lie. They always will be true because they behave as they can. And you see, Haley was already on the way to have a hip replacement, or could not live, and she had stem cell injection, and as you can see, she stopped limping right away. Furthermore, we had Achilles tendon ruptures examined in rabbits, and we have seen that we had drastic, really impressive results by using stem cells together with a matrix instead of just using matrix for a rupture. And not that only the macroscopic texture was much better, also when we went into histologies and special stainings, we have seen much superior results in the stem cell group than in the non-stem cell group, which nearly like complete normal tissue. Here's another example of a tendon which has been partially ruptured with a racehorse and was treated with just a stem cell injection. And you see that after 4 weeks already the damaged lesion was completely restored back to normal. And there is another case of a high performance horse with the same injury. And have a look at the right back limb, or as limping on the left side, and then after the treatment on the right side, the horse is having a complete normal and great and pain-free, I estimate, walk. Coming on to cartilage, what Professor Alt just presented to you is, if we create a cartilage defect in a rabbit model and we only let it heal, we're going to have a huge and overgrown fibrocartilage mass. While if we do it with stem cells, we have a very nice restored cartilage with which is hyaline and not only hyaline-like, which is hyaline, and which has this contact zone with no border anymore. In a clinical study, we could have shown that 1 year after treatment in 22 patients, or 21 patients, 22 knees, the quality of coverage from a before seen defect raised up to 4.5 out of 5 points, and all patients showed significant improvements, not only clinically, but also in the second view, as you're going to see later. So we can say, compared to eventually knee replacements, which takes the patient out of a working and a good living capacity for a longer time, the ADRC treatment was a quick and very, very effective one. There is an example, as you've seen before, with this cartilage defect on the left side, where we microfractured and added stem cells, and in a second look, after a year, you can see that the cartilage defect was gone and completely covered with hyaline cartilage and not hyaline-like. And there is also, in another example, you see a contact zone. There is no overgrowing. It is really reconstructed, redeveloped new healthy cartilage, as we can also see in this example. And there is another one with a comparison. There was the left knee 1 year after debridement and microfracturing, which is state-of-the-art in those patients, just as a last try before you eventually go for a partial or total knee replacement. While on the right side there was a cartilage transplant which failed, and you see these little dots in the tibia, which has been retreated with removing the non-working cartilage and adding stem cells. And I think the pictures are talking for themselves in between the right and the left side. Also, the histologies by staining showed that on the ADRC treated patients, we have an absolute cartilage regrown, while on the control group we have this hyaline cartilage with not a lot of cell columns result. As you can also see in the next picture, we have these typical columns on the left side, these tower buildings, while on the right side we do not. Another field which is involving all of us is the back pain. A lot of people experience back pain, and there are literature who's showing that back pain is the single leading cause of sick leave and disability, and creates a lot of costs. And it is really, really demoralizing if you're suffering from back pain. And our head of neurosurgery, Professor Rothwell, did an incredible prospective clinical study with patients who has a facet syndrome. You see 3 MRIs of high-profiling skiers. One of them is active, 2 are non-active anymore. And what you see is, while the disc is still normal, where the yellow arrow is, it's full of water, it's very elastic. Where the blue arrows are, due to the high compression forces, the liquids are gone. And there is an inflammation of the facet and the xenomer. And just by an injection stem cells in those facets, the visual analog scale for pain went down drastically, and the patient became pain-free, and the one skier is back entering in the World Cup and did the 3rd place this season. Another case is here, a ruptured ligament of an external ligament of the knee, which would have been replaced years ago. Right now, we readapted, we add stem cells, and a short while later, like 6 weeks, we already seen not only the clinical stable result, we see a healed MRI result. This is for me one of the most impressive and testimonial results I've seen. We had a knee, and this person was meant to undergo a knee replacement. As you can see, he had bone cysts. His cartilage was worn down, and his meniscus was torn and not supplied anymore. 10 months after 2 treatment with stem cells, the bone edema was gone. The cartilage started to regrow slowly, but it did. And most impressive, the meniscus, which is also cartilage tissue, regrown. It restarted being normal, and the patient is running around, sailing and hunting. Same here in the hip necrosis, which is a typical disease after steroids. This young patient my age was, no, not young. This patient my age, sorry. Too young for a hip replacement, as we heard. This patient came over because he should have undergone a bilateral hip replacement. And we could save him by drilling and adding stem cells. And while he was also obese due to his immobility, he came back on track pretty quick. Another case is this non-union, treated over 3 years and done surgery and ongoing pain. And you see the red arrow. There is a narrow in between the 2 bones because it didn't heal, although it was surgery. And just by adding stem cells, the bone started to regrow and became a stable foot. There must be a video there should have been a video in the end. Yeah. We have until now treated over 200 cases in the orthopedic field. We see it's a highly effective therapy without adverse events, and also because there is a high anti-inflammatory, immune modulatory, angiogenetic, and anti-apoptotic effect of those treatments.
The problem was I had an operation on my foot. I went to the best orthopedic group there that has the Houston Texans football team. They have all these sports teams. And I said, well, listen, I've got this problem with my foot. And they x-rayed it, and they said, yeah, your metatarsal is broken. But I let them do the operation, and it lasted about 1.5 years. I was hunting, and the metatarsal cracked again. I said, my knees are hurting. They said, well, we can fix your knees, you know. About $300,000 to do 2 artificial knees. Then that's when I lost total faith. So with Professor Alt's application and his centrifuge here, it concentrates the therapeutic cells. So we worked for putting stem cells in the knee, and he repaired the ankle, and it had 2 crossed, actually titanium rods in it, and they were rattling around in the bone, and we just fixed it with stem cells. This knee is about 80% healed, so I came back. Tomorrow I get another 20, 30 million stem cells put in here. I was lifting weights, and I pulled a tendon up here, so I flew immediately to make an appointment for him to take stem cells, put in there, and avoided an operation, and the tendon grew back to the muscle. So I'm a big believer now in this clinic and regenerative medicine.
Thank you.
Before we get to Dr. Glassberg, Dr. Schoettle, let me just ask a couple of questions. Highly effective without adverse effects is what your last slide said.
Yeah.
Can you elaborate a little bit more? 200 patients, what percentage did have benefit? Were there one that did not get any benefit?
For sure, in our clinical trials, we also have patients who did not all have the same improvement. We have patients like Mr. Bozarch, who came more or less with a stick and right now is running around. And we also have some patients, we have a partial improvement, but then coming back after a year. And I think those are the patients we learn on, because eventually it's a little bit too late already, or we are asking too much of the stem cells. But we have not seen anyone who became worse or the same. They all improved in different levels. And we are starting to understand more and more how to applicate where and how much. And we are moving towards, and the promising results we see is impressive. I think the future will, in 2 years, we're going to sit here and have much more to say and give direct indications how and where, combined with surgery or not.
And I just want to be clear, like you gave the example of an Achilles tendon tear, for example. Typical treatment may be anti-inflammatories and immobilization. Do you not do those things when you're giving the stem cell injection?
Sure we did, because you always I have to consider, don't overstress a system. So make it as is and add stem cells. I've seen my patients recovering so much faster. The pain period became lower, and postoperative ultrasound examination showed less functional scar tissue and much more normal tissue than when I treat them with a complete, let's say, the conservative treatment, as you said, immobilization and having anti-inflammatories. The next step is already that we do to bring them faster back on track, but it's a step-by-step procedure. Think what happens if I say, you have stem cells, go running again. I have the safe line, but a faster and much pain-freer healing and a more safe healing.
Okay, and I'm going to come back to you a little later, talk a little bit about cost and cost comparison to existing therapies. But lung disease is one of the most challenging diseases to treat sometimes. Dr. Glassberg is going to give us a little bit of a presentation about some of the clinical results in this area.
Thank you, Sanjay. Thank you, organizers. Thank you, Robin. I'm very pleased to be here. So yes, I'm going to talk to you about application of mesenchymal stem cells. These are not hematopoietic, for those of you that were in the audience yesterday listening to Dr. Burt. These are mesenchymal to repair damaged tissue in lungs. I'm going to talk to you about a bunch of diseases that look like this. If you look at their survival, which is shown to you in this graph, these diseases, including ones that probably some of you are very familiar with, idiopathic pulmonary fibrosis, and chronic lung diseases, have a survival that is comparable to the poor survival in lung cancer. And you can see how much better colleagues are doing in breast cancer and colorectal cancer. So these are complex diseases. They don't have a simple fix. Pharmaceutical industry got interested in them in about the year 2000, and you can see on this graph, if we start up at the left-hand corner and follow it counterclockwise, we can see that there are several different aspects of a lung unit called an alveolus, which, if you think of the lung as a big sponge that you might clean your car with, the units that are alveoli are all the little units of the sponge. And what happens in this disease is that those units don't function anymore, and the structure around them becomes impaired. Patients lose the ability to get the oxygen from the air that they need every time they breathe, and they're basically asphyxiating. So they're short of breath, and you've seen these patients, you've seen them on chronic oxygen. They're really very debilitated. If we follow this around and we look at the little red bars that I put in here with the little crosses, these are the areas that the pharmaceutical industry has come in and tried to generate drugs, some of which you'll be familiar with because they're from our friends in the cancer world, to try to stop this process. And as you've heard in the last couple of days, unfortunately, although they may try to stop the process, what they really do is only slow the progression. So two agents were actually approved last February. We worked almost 12 years to get those agents to market, studying lots of patients in phase 1, phase 2, phase 3 trials that we've also talked about. And unfortunately, millions of dollars later, we don't have a cure. But we have the options of using these drugs, of understanding very intricate pathways that go through very different parts of this unit to try to affect how it functions. So what can be done, maybe not to look so much at the parts, but think about the whole? How could we develop a therapy that might be able to take care of all those different parts on that counterclockwise pathway that I showed you that could fix it? Remember also that when I showed it to you, it doesn't close, because the lung is an organ that doesn't know how to repair. And there's really no evidence right now that by itself it can fix itself, whereas the liver has this ability. So some of the chronic lung diseases that we've thought about looking at and have been looked at include acute inflammatory conditions. You've seen patients that have been in intensive care units with acute respiratory distress syndrome. This is really an inflammatory condition when it starts. Seems like what Dr. Alt showed you in terms of all the products of these cells could be very impactful in making a difference in this disease. What about chronic conditions? What about chronic asthma? That's one that's a chronic inflammatory condition. It has a relentless cycle. Patients are using their inhalers, taking steroids, but they're not cured. What about other diseases, rare diseases, right? Bronchopulmonary dysplasia in children, non-CF bronchiectasis. This is not cystic fibrosis, but non-cystic fibrosis bronchiectasis, which means that those units that are around the lung now become architecturally changed. The lung doesn't even look like a lung anymore. Instead of having airways that are nice and long, they become wide. The air that has to come through can't get through. So these are architecturally destroying diseases that may have a strong inflammatory component as well. And then, of course, the disease that I'm going to spend a bit of time talking to you about today, idiopathic pulmonary fibrosis, a really progressive disease that starts with an inflammatory pathway and is truly relentless. So I mentioned that we wanted to know how these stem cells might work, because why stem cells? Well, Dr. Alt showed you that they're packed with stuff that can do the job. Rather than giving multiple pharmaceutical agents, we may be able to give a cell that can do the whole job. Well, where do they go? What's been looked at? And this is a study from Kretschmann in 2005 that shows in dogs lying on their side, you can see in the green parts that within 1 hour, these labeled mesenchymal stem cells end up in the lung. And in 24 hours, they're in the liver. So there's not too many that actually stay in the lung. They seem to go there, probably do their work, do their job, and could the job be something that we could utilize in lung disease? So how would they work? So there had been a lot of work done in cardiology, a lot of it done by my colleague Josh Hare in Miami, where they had put in intravenous stem cells and seen results in cardiology. And I knew a couple of things when I embarked on this in 2013 I got very frustrated with working with these drugs that weren't working. And I realized that the first pass when you give something intravenously actually goes in your lung. It doesn't go in your heart, it passes in your lung. And if you looked at the trials that had been done, they really had shown quite a bit of safety, not so much efficacy, effect, because what has to be done first when you're studying something is to show that it's safe, right? We don't want to give things to patients or animals that we think are unsafe. So the mechanism of action of this is that they would go to the lung, they would dump their products, do whatever they could do, and induce a repair process potentially in lungs that couldn't repair. And I mention this because what you heard about in the skin and in the joints is autologous. In other words, it's the patient's own cells. I think we would argue in lung disease that your own cells aren't working in chronic lung disease because you're not fixing your problem. And so what we've looked at is what's called allogeneic cells, cells from young male donors or even younger sources of cells that could in fact have more impact because they haven't been around as long, they aren't old, and they are still really able to work. So what's been done? Mostly what's been done is phase 1. I show you in this chart that many lung diseases have been looked at, including trials in pulmonary hypertension, trials in lung transplant, and more recently in other entities in lung disease with many planned trials. At the university, we've expanded the lung program with a lot of help from very important organizations that I'll talk about later in terms of obtaining INDs from the FDA, both for the first-in-man human trial in patients with idiopathic pulmonary fibrosis, which I'll present some of it today, as well as 2 new trials in non-cystic fibrosis bronchiectasis, as well as in patients with asthma. It's going, it's moving. So I mentioned that when you start something, you want to make sure it's safe, right? And when you first test it, you want to make sure it's safe. This is just to show you, if the red bars come up, that there was safety and a little bit of efficacy in the animal studies. How could you get efficacy in safety trials is that these are really done with what's called secondary endpoints, sort of exploratory. Could there be an effect? Would that help me design future trials? And in the human studies, I show you this is just the lung. That there was indeed safety in a study in 2013 in patients with COPD done by Osiris Therapeutics, now owned by Mesoblast. Souflakis in Greece, who actually put the cells down the airway and the trachea and labeled them and watched where they went. Very small numbers of studies and very short period of time. If you notice the time period of these studies, Chambers in Australia did a 6-month study, and Wilson more recently with Mike Mathey at San Francisco has looked at patients with acute respiratory distress syndrome. Importantly, very safe, and as I told you, some signals of effect. So let's talk about the progression of chronic lung disease and why pharmaceuticals probably won't work, but where stem cell therapy looks extremely promising. These diseases are all unpredictable and fatal, meaning that patients get the disease, but you can't tell them, well, you know, in 3 months you're going to get worse and this is what you're going to get. You don't have any markers in their urine or their blood to tell you the course of the disease, and unfortunately, they die. If they are young enough, they make it to lung transplant, where they're on 5 to 7 drugs a day. They have quite an impaired lifestyle, but they're alive. Many of these patients, particularly if they're transplanted younger, do very well. But unfortunately, idiopathic pulmonary fibrosis and a lot of the chronic lung diseases are diseases of older patients, above the age of 60. Now, we don't think of that as that old, but indeed, they're not teenagers. So in these diseases, there's a 5-year survival from diagnosis, about 20 to 40%. The age of onset, as I mentioned, over age 60. And what I show you in the top slide are CT scans, and in the bottom, the pathology. So if we start at the left, you see the scan is very black, looking good, spongy, if you could look at the lung, and in the CT scan, and in the bottom, the pathology. And as we move across, you start to see more of this white pattern, right? And the white pattern seems to take over as we look at the top of the CT scan. This is all fibrotic lung tissue. And it's really shown to you very well in the pathology, because in the second box of the pathology, you still see the white areas, right? These are the alveoli, the lung units that you can see, but all that pink stuff that's staining is actually the destroyed architecture of these lungs. It's almost like cement. And as you go along till you get to the last slide, this is progressive, where you don't see any more of the white units. You just see these open lakes of really dead area where the lung cannot gas exchange, right? Cannot pull the oxygen from the air that the patient needs, and this patient is truly suffering. These are patients on oxygen, they don't get around. We have to really do a lot of what's called really emotional backing for these patients and palliative care. We would like to avoid that. So we decided that we would, importantly, try to develop a model in mice that was representative of the human disease. And over the years, most of the studies had been done in young mice, 6 to 8 weeks old. And I just mentioned to you that this disease and these diseases are actually of a different age group, right? Above the age of 50, 60, older patients. And so we developed a model in old mice, 22-month-old mice, which is actually equivalent to a 70-year-old man. If you put these mice on a treadmill, which I didn't bring these hyperlinks to show you today, thought you saw a lot of videos, but they really make their way very slowly up the rank. They can't do very well because they are severely impaired once they're given a very severe disease. And there is some overlap with aging, right? These lungs have aged a little bit, and we'll talk about this this afternoon, I know, in a session. But let me show you a little bit about these mice. So in the upper left-hand corner is what's called the control. These are mice given saline. The saline is given intratracheally. And in the right side is bleomycin. Now, bleomycin is a known chemotherapeutic agent given to cancer patients that has been recognized for years to cause pulmonary fibrosis. And in the mouse, it's very interesting. You can give that animal 1 intratracheal dose down the trachea of bleomycin, and they get fairly fulminant fibrosis. And I'm showing you day 21 data. This was published last December. So in the bottom left-hand corner and in the right-hand corner are the 2 key points for you to focus on. The left-hand corner shows you the mouse given young adipose-derived stem cells from a different mouse, right? These are not autologous. They're given from a young, healthy mouse. And what you can see is that this disease looks very similar now to the saline mouse. versus in the right-hand lower corner, there's been no repair and, in fact, worsening. What's interesting is if you take these same cells and you put them back in the young mouse that should do okay, they also develop fibrosis. So there's some transfer now of what's happened in terms of developing the severe fibrosis. But importantly, the take-home message here is that the young cells appear to be able to repair this disease. So how do we think this might work? And which led to how we got permission to go to the human trial. If this video is going to run, let's see. The cells are going to be given intravenously. Let's see, does it work? Do you want to run the video? Hello? Doesn't look like it's going to run. Oh, there it is. So the cells come in, they're given intravenously. They dislodge their, you can keep running it. They dislodge their products, right? Some of which we just heard about are exosomes. Parts of the cell itself carry the important message for repair. And they induce repair in these lungs. We now have evidence from some very beautiful CT scanning images which have labeled cells to show us that the lung is in fact changing, right? And it will be important to do human trials that will track this over time. But what's nice about this chronic model in mice, we also have CT scanning for mice. We can follow them over time so we don't have to kill them to find out what's going on in their lungs. We can actually follow them like patients. They're really cute, actually. Okay, so let me tell you in the last few minutes now about the phase 1 trial that's been completed. Will be completely presented at the American Thoracic Society in 2 weeks in San Francisco in a platform presentation. So this is the study design. Just to let you sort of see how we lay it out for the FDA when we present it, is there were 9 patients in this study, 3 that received 20 million cells, 3 that received 100 million, and 3 that received 200 million. This is the longest study ever done in lung disease in man. It's a 60-week study. We now have data out to 2 years and 5 months. This is a safety study. Right? So the primary endpoints are safety, shown to you in the bottom left-hand corner, with some exploratory endpoints on the right-hand box that turned out to be very important for us and has helped lead us now to the phase 2 study. When we look at lung disease, particularly fibrotic diseases, there are 3 parameters that are used to decide if there's an effect. Remember that it's first a safety study, and secondly, a study to look if we're having any impact on the disease. So the first one we use is forced vital capacity. This is how much air a patient can get out of their lungs, and we measure that. And the parameter that's been used as a standard throughout the world now is a change of greater than 10% the absolute value. We also use walk distance, standard to look at greater than 50 meters. And finally, the diffusion capacity, which is greater than 15% change. Why is that important? That's all about the gas exchange and the oxygen. We can actually measure that. And that's really seminal in a disease that I showed you can be so destructive, leaving the patients without the ability to capture the oxygen from the air. This is now some of the data from the trial. I'm just going to show you very briefly. So remember, this is a relentless, unpredictable disease where patients continually deteriorate. So if I show you stability, that's really impactful. And so that's what I'm showing you. This is the absolute decline post-infusion minus the baseline, right? So we always want to know where a patient starts, where does a patient end. And in all of the cohorts shown to you up in the left-hand corner, you see stability and this ability to get the air out. And if we look just combining cohorts, it also changes. And you notice that this change is only 3%. In all of the pharmaceutical trials that led to the approval of those 2 drugs, that change was between 8 and 10%. So we've beat the bank on this in a very, very small study. Be careful, it's a small study. We don't want to come to too many great conclusions about all of this. What about walk distance? You can see how the patients behave. So they initially decline from baseline, then they improve, and then there seems to be a decline again, suggesting that one dose won't do the job from a young donor, that we still need to, the disease process may still be going on, but this still exceeds, if you look, this is looking at the average improvement, we still are surpassing any of the pharmaceutical trials. What about diffusion capacity, the ability to deal with the oxygen? Let me just show you stability. And more importantly, this gave us information about dose. If you focus on the middle bar at the bottom, you can see that the diffusion actually had an absolute decline of only 1%. This is remarkable. Small number of patients, though. We want to be careful not to be too enthusiastic, but very, very promising. So the conclusions, where are we at? We're at a disease that was unpredictable, fatal, relentless, leaving patients on transplant with some hope. We know that the mean change in this ability to garner the air is now below 5%, which is really surpassing the pharmaceutical trials. We've also got improvement in diffusion capacity as early at 24 weeks, with improvement of walk distance at 36 weeks, and lung function, right, overall at 48 weeks. This data has also led us to understand that even though in a small number of patients, the likely dose is going to be the 100 million dose, which we have now been approved to do in a repeated dose design, and it's safe, as Sanjay just said. This is really important, right? We want to make sure that we're not giving a treatment as with pharmaceutical agents that leave patients with side effects, right? We treat with something, but we give them a disease worse than the disease they got, and their quality of life is so poor. That's not this. These patients do very well. And the most common adverse event was an adverse event that we know very well, being bronchitis. So future directions is now. We really need to move quickly, I think, in a lot of these diseases. We've got a lot of information about how these cells work, what the products are. Perhaps being able to give a cell-free product is not too far away, and we're working very much with our collaborators. I want to make sure I thank the people that make all this possible. The Lester and Sue Smith Foundation for funding all of the work in idiopathic pulmonary fibrosis. The Marcus Foundation for funding the non-cystic bronchiectasis and the trials in asthma. And then the National Institute of Health for establishing our network, which did not get reestablished across the country. We talked a lot about collaboration yesterday. This was a phenomenal movement from the NIH to network all of the main centers. There are about 20 of us that could then exchange data, and it didn't get refunded. So now we're regrouping and trying to figure that out, but really with the help of Lester and Sue Smith and Marcus Foundation, we actually network ourselves and are able to do some very pioneering work in this area. I want to thank my study team pictured here, all of the smiling faces. I can't do the work without them, and Dr. Sharon Elliott in the laboratory. Thank you very much.
Thank you. Thanks for sharing those early results. In the interest of time, I'm going to move right on from the lung to the heart, and Dr. Skerritt's going to talk about, I guess, what are phase 3 clinical trials with regard to cardiac failure.
Thank you. Again, thank you to the organizers for this opportunity to share the Mesoblast story with mesenchymal cell therapy. So Mesoblast is developing mesenchymal precursor cell therapy for the management of heart failure. We're a publicly traded company, so hence this forward-looking statement. Next. So mesenchymal cell therapy is considered a disruptive technology platform. Well, what does that mean? It means we're different, we're novel, we're not the standard small molecules that drug companies and regulators are used to looking at. We're not the typical hematopoietic cell therapy for which there's many, many years of experience. So we're different. Sometimes regulators don't quite know where to put us, and pharmaceutical companies consider this something that may change the way medicine is practiced. So there's an awful lot of thinking that goes on about where this therapy belongs. Luckily for those of us who've worked in this field for many years, we've known that the promise is there, and we've continued to move forward. The mesenchymal lineage cells that we work with are of two types. One type is a precursor cell, which is immunoselected. The other is a culture expanded cell by a slightly different mechanism. The cells are fairly ubiquitous in the body. They're located around blood vessels and all vascularized tissues. As you've heard, they respond to signals associated with tissue damage, and they have the ability to recognize and to home to areas of inflammation. So they know where to go to get to the site of injury. When they get there, they secrete a diverse variety of biomolecules, and you've heard about them earlier today. And these are the molecules that are responsible for initiating and effecting tissue repair, as well as immunomodulation. These cells are isolated. They can be isolated from multiple sources. Our cells are isolated from the bone marrow. And they're obtained from a single healthy donor and then expanded to provide thousands of doses. So here we're talking about an allogeneic donor, someone who's unrelated but who has a history of being healthy and a history of being a donor. And from that donor, we're able to bank thousands of donors. Now, there's certain properties of these cells that allow this to be done. Those are predominantly the immunomodulatory properties that mean these cells are relatively non-immunogenic. They do not initiate a rejection. They do not initiate a clinical immune response. And this allows us to scale this up to a range that would be feasible for commercial applications of these allogeneic cells in a manner that we call off-the-shelf. The product candidates that the company is developing, we've developed this pipeline over many years. I'm thrilled to say that at this point we have a number of programs that have reached the phase 3 stage of development. And the phase 3 programs, you heard about acute graft versus host disease just the other day. The heart failure program is another one of our phase 3 programs. And then we're also doing a phase 3 trial in chronic low back pain due to degenerative disc disorders. Chronic heart failure is our lead program with the mesenchymal precursor cell. It's in development for patients who have what we call New York Heart Association class 2 to 4. So these are patients with symptomatic heart disease. And heart failure affects over 5.7 million patients in the U.S. alone. 870,000 cases are diagnosed each year. And about 1.9 million people in the United States are living with NYHA class 2 to 4, and they're patients who have low cardiac function, and they're symptomatic. And I like to think about heart failure as it's an insidious disease, because what happens is patients adapt to being able to do less and less. And sometimes, they don't realize how much they've deteriorated until someone sits down and does a thorough evaluation and they realize, I'm not able to function, I miss family events, I don't get out. And so it's for this reason that there's a continuing need to develop therapies for heart failure that, one, are going to halt the process. So what we see with many classical medical approaches is that we're able to manage symptoms, and we're able to manage them very well. But the ultimate outcome of diseases like heart failure has not changed over the past decades. So the gaps that we've addressed or are addressing are two. One is the class 2 and 3 heart failure patients. These are patients who have low ejection fraction, so their hearts don't pump very well. And they are at high risk of repeated hospitalizations as well as mortality, despite standard of care therapy that's available. And then there's another class of patients who we call class 3-4. They're the end-stage heart failure patients. And for those patients, the only real salvage is to receive a heart transplant or a mechanical support device, such as the LVAD, left ventricular assist device. And as you know, heart transplants obviously are limited by the number of donor organs that are available. So there are a number of patients who receive an assist device either to bridge them until they can receive a transplant, or for some patients, they live many years with a ventricular assist device that's implanted. So what our pathway is to market, which means access, is that we are currently conducting a phase 3 trial of approximately 600 patients who have advanced heart failure with poor ventricular function. And we got to this phase 3 program by conducting a phase 2 randomized clinical trial in heart failure. That program consisted of 60 patients. Both of these programs have control groups. And prior to going into phase 2, we did extensive preclinical work. In our case, the preclinical work was done with ovine or sheep models using allogeneic cells. And we tried to use the same cell type and the same procedures that we plan to use in humans. So we use catheters to deliver the cells directly into the heart. And what those studies helped us understand is what doses are likely going to be appropriate, and also showed us that the biological activity seen occurred by mechanisms that we sort of anticipated, by anti-inflammatory, anti-fibrotic, regenerative, and neovascularization mechanisms. So this is just a snapshot of the phase 2 study that supported going into phase 3. 60 patients were studied. We looked at 3 doses, and we had a placebo control arm. At 6 months, we saw effects on left ventricular end systolic and diastolic volume. So this is how big is the heart, how much blood is sitting in the heart, because the heart's not appropriately pumping it out. And we saw that with the highest dose used, 150 million cells, that we saw the greatest effects in terms of reducing the volumes over a 6-month period compared to control, and also within the individual subjects in that group. We also showed, as shown in the panel on the right, that over 36 months, patients receiving this highest dose, 150 million cells, had significantly greater probabilities of remaining free of heart failure MACE. So what does that mean? It means they didn't have the events that were anticipated and the events that were seen in the control group. Those events were things such as cardiac-related death, resuscitation that could have led to death, and heart failure events, mostly requiring hospitalization. So we're starting to see with the phase 2 study that there might be an effect here. And we also importantly demonstrated that these cells, these are allogeneic MPCs, they were well tolerated, and we did not see clinically significant immune responses. And particularly in this patient population that might have to go on to transplant, we would not want to have a therapy that might in any way compromise their ability to subsequently receive a transplant. So where we are today is we're conducting a phase 3 program. The study name is DREAM Heart Failure 1. It's a double-blind, randomized controlled, placebo-controlled study evaluating the efficacy and safety of our allogeneic mesenchymal precursor cells. The patients are those who have severe advanced heart failure, and the objective of the study is to evaluate the risk reduction for recurrent heart failure events. We're recruiting in this trial across North America. We've recently expanded into Europe. The patients in this study are what we call enriched for high-risk events. So these are patients who've previously had a heart failure hospitalization, or they have certain biomarkers that are indicative of severe heart failure. The cells are delivered by a single injection through a catheter. So a catheter goes into the heart and injects the cells into the heart muscle. And our endpoint of the study, how we will determine success, is by comparing the time to the first and subsequent recurrent events in the treated patients compared to the controls. And as I mentioned, we expect to study about 600 patients to see the number of events that would be required to draw some conclusions about success. And just a little bit about what's involved in conducting and governance of a study like this, is there are multiple governance committee overseeing the activity to make sure this study provides results that are going to be meaningful. And I'd also quickly just like to mention that that other group of patients who we call end-stage heart failure patients, we've also, in collaboration with the network through the NIH, initiated a study in 120 patients who are supported by left ventricular assist device. So these are patients who have severe heart failure. That trial is ongoing at multiple sites in the US. It was supported by a phase 2A study of 30 patients who received a lower dose of cells, and demonstrated to us, first of all, that the cells were very well tolerated. There's no increase in sensitization, and that we were seeing that patients who received the cells, their hearts got strong enough for them to tolerate weans off the machine better than the control. And these are what we call important signals that help us then develop the subsequent study, and that's the phase 2B study currently being conducted. So I'd like to close with that and thank the moderator and the organize this as well.
Great, thank you very much, yes, thank you. We'll move right along, Dr. Bravo, talking about the use of stem cells for fistulas in Crohn's disease, please.
Thank you, and again, first of all, thank you to the organizer for inviting us to share with you this excitement that we have in bringing a product so close to the market. By the way, I'm not a medical doctor, so thank you for the introduction, but almost. So let me start again. We're a public company, so I'm sure that I'm going to be making plenty of forward-looking statements, so beware. I think that August 2015, we really became probably the happiest team in the world by being the first ever prospective phase 3 randomized clinical trial with allogeneic stem cell therapy to report positive results. So after a lot of years, finally, we made it through, and we could announce to the world. Unfortunately for our shareholders, we announced the same day that China collapsed. So, the result was not as expected financially, but I think that was a major breakthrough for the field. This has not been an easy road, and it's taken 16 years to get exactly through that wall, and that started by actually an individual doctor in Spain that came with the idea of using these adipose-derived stem cells to treat complex perianal fistulas, believing that the cells will home into the body of the patient and will fill this fistula tract. Today we know that that's not the case, but that's less relevant today. We took the product in 2004, and we've worked 12 years in getting the product through all the regulatory hurdles and the clinical development that is required for a product to make it to the market. A lot of people have said that it takes a village. We have our own village in Spain, so there were a lot of people that actually made this possible to get this product through. And of course, I'm not counting here the number of hospitals, clinicians, and patients that participated in the development of the compound. Unfortunately, I'm going to spare you the pictures and the videos. Working in this indication, I have always this difficulty of trying to explain to people how difficult and how debilitating these complex perianal fistulas are for the patients that suffer them. This is a very common disease. There's 1.5 million Crohn sufferers in the world between Europe and the US. 10% of those Crohn patients will develop these complex perianal fistulas. Those fistulas are these connections between the rectum and the perianal area through the non-anatomical channel. And again, here, of course, we have a small fistula, but I can tell you that those are extremely debilitated patients that sometimes cannot go out to work, that need to wear diapers, that have, lose their stool content through those tunnels. And it's, of course, an area that is very difficult to heal because it's always humid and, it's full of content that produces, big abscesses. So, in the majority of these patients, really nothing works. How are those patients treated today? They go through the full therapy of, getting antibiotics to try to cure the infection, then get immunosuppressants, and then most of the patients get anti-TNFs. Remicade is the only approved drug for this indication, despite, very limited long-term efficacy, despite, needing to go to the hospital every 8 weeks for an infusion, and despite very serious adverse events with the continuous use of anti-TNFs. Some of those anti-TNFs have, for example, a 5% risk of tuberculosis as a black box warning. So those are very efficacious in some indications, but very badly tolerated drugs. Some patients that have gone through all these therapies may have to go through surgery. Again, the problem is, especially in Crohn patients, the area is extremely damaged. The tissue is inflamed. So surgery is a last resource. In a lot of cases, about 1/3 of the patients that undergo surgery will end up being anal incontinent. So, when you talk to doctors, it's an indication in which you lose your reputation. That's what they say, because you have very few happy patients and a lot of young and happy patients. Average age is about 40, just to give you an idea. Again, there's a very recent paper. To close a fistula, on average, a patient goes through 7 surgical procedures. So just imagine the burden for the patients. What do we offer? You know, we were talking about this cell therapy. What we have is an allogeneic, so we start with the fat of a healthy donor, and you know, there's plenty of donors in the world of fat, and from one single fat donation we can produce 2,400 doses of this CX601, as we call the product. So we can mass produce, and all we deliver to the hospital is those 4 vials with 30 million cells on each of them. And it's a very simple procedure. The doctor will thoroughly clean the fistula, and that's required in any case for the normal treatment of the patient. They will put this internal stitch, so they will have a stitch on the internal opening of the fistula. Again, something that is best possible care. And then all we require is with a normal syringe to produce half the dose around the internal opening and the other half in a few blips around the fistula tract. So it's an extra 5 minutes to the normal cleaning and treatment of the fistula. You know, with those simple results, you know, we were asked to prove that this works. So I think that I went one too far. Sorry, can you go back one? You got all the excitement already. So let me see.
Go back one slide, please.
Yeah, here we are. So we were asked, and we did what is today the largest finished phase 3 clinical trial. You know, we recruited 289 of those patients in 7 European countries and Israel, and opened, you know, up to 52 hospitals, 47 of them recruited patients. This was a randomized, double-blind, placebo-controlled trial. So we were, you know, patients didn't know, doctors didn't know which therapy they were receiving, and you know, we asked also for an MRI to ensure that the fistula was properly closed. And again, there's no other clinical trial in this indication that has required this. You know, the fistula needs to be closed, and through an MRI as well, you need to see it close. And as I mentioned, you know, in August of last year, we announced the results. The results shows that compared to best possible standard of care, this is a placebo control, both arms receive best possible medication, you know, anti-TNFs, immunosuppressants. There's a 44% increased chances of achieving combined remission if you're giving 601. Very, very importantly, we've announced as well earlier this year that when following those patients for a year after just one single dose of CX601, more than 50% of the fistulas remain completely closed. You were asking before about the side effects. You know, again, there's absolutely no difference on the side effects of the two groups. So injecting a saline solution or injecting 601 produces exactly the same side effects, which is, as you can imagine, nothing. So, you know, with that, you know, we remain very committed. We filed for approval in Europe, and we expect that, you know, in a little bit over a year from now, we would make this product available to the thousands of patients that today do not have a proper treatment for these complex perianal fistulas. Thank you.
Thank you very much. Thank you. I know we're running a little late on time, but I don't want to cheat you of any time, Dr. Khera, because I'm truly interested in what you have to say about the use of stem cells to enhance blood flow, presumably. Yeah.
Well, good morning. It's truly an honor and a privilege to be here. I want to thank the Stem Cell for Life Foundation, Ed, Robin, for giving me the opportunity to discuss mesenchymal stem cells to treat erectile dysfunction. I first want to give you a scope of the problem. I want you to realize that erectile dysfunction is estimated to affect 30 million men in the United States and 20% of men worldwide. Approximately 322 million men worldwide are expected to suffer from ED by 2025. Also realize that 15% of men actively trying to conceive a child suffer from erectile dysfunction. We know that men with ED are much more likely to have anxiety, depression, low degrees of self-esteem, negative outlook on life, and emotional distress with their partners. There are many etiologies for erectile dysfunction. I'm not going to go through them all, but realize that there's vascular, neurologic, penile trauma, hormone imbalances, medications, and psychogenic causes as well. However, I would argue that one of the biggest risk factors for developing erectile dysfunction is actually aging. In fact, if you look at one of the largest studies, roughly 1,300 patients, they found that roughly 52% of men between the ages of 40 and 70 suffer from some degree of erectile dysfunction. And if you look carefully at this graph, you'll see something interesting. 40% of men at 40 years of age had ED, 50% of men at 50 years had ED, 60% at 60, 70% at 70. In fact, if a man lives to 100 years, almost 100% will have erectile dysfunction. So I have to describe the mechanism of erections. It's very important. Realize that the penis is just two muscles running in parallel. There's an artery coming down the center, surrounded by muscle, and then there are veins on the periphery. As blood comes in, the muscles then compress the veins and prevent the blood from leaving. The problem is as men get older, they develop fibrosis of the muscle, and they get a loss of smooth muscle content. Therefore, the muscles are no longer able to compress the veins, and this phenomenon is called venous leak. It's actually the #1 cause of erectile dysfunction in the world. If we were able to prevent the fibrosis, if we were able to prevent the loss of smooth muscle, in one way or another, we would actually find a cure for this disease. I present to you the current treatment options that we have available. And most of you are very familiar with the oral medications, Viagra, Cialis. There's also urethral suppositories, injections, vacuum pump, and penile implant surgery. But I hope if you look at this graph, you'll see something very interesting. 99% of the treatment options we have available are not curing the problem. These treatment options are actually just masking the problem while the disease continues to get worse every single year until these medications are no longer effective. So again, we still do not have a cure for this disease. And in fact, if you ask patients, what is the #1 concern? What is the most important consideration when starting an ED medication? Patients would say, I wish there was a cure for this disease. If you ask patients what's the most important reason for discontinuing ED medications, they will tell you the #1 reason is these medications are not effective. Well, times are changing. Over the past 10 years, we've used pharmacotherapy, but there's been an explosion in terms of gene therapy, stem cell therapy, transfected cells, and tissue engineering. And I would argue that stem cell therapy probably has the most promise for the future treatment of erectile dysfunction. These are animal studies that have been published. Thus far, there have been 34 rat mouse studies, all consistently demonstrating improvement in erectile dysfunction. There have been 2 models that have been described, the diabetic model and the cavernous nerve injury model. The most common types of cells used are adipose-derived stem cells, sometimes muscle and bone marrow, and the most common injection is direct penile injection into the cavernous muscle. One of the most fascinating studies was by Dr. Albertson, who took these rats, gave a cavernosal nerve injury, and he injected either vehicle, adipose-derived stem cells, or the lysate. As many of you know, the lysate is not the stem cells. It is just the conditioned medium in which the stem cells were in. They had 8 animals that had a sham study, and they measured intercavernosal pressures as a standard for measuring erectile function. As you can see in the sham animals, there's good erectile function. Those animals that had nerve injury with vehicle injection actually had very poor erectile function. If you inject adipose-derived stem cells into the penile tissue, there's a significant improvement in erectile function. But what's very interesting is if you inject just the lysate, no cells, you also see a significant improvement in erectile function. So many studies, including this one, have shown that when you inject stem cells and you label them into the penile tissue, they don't stay there. In fact, some studies show within 14 to 28 days, those cells are gone. In other studies, within 3 to 7 days, those stem cells are gone. So how is this mechanism working, and what's really occurring? We know now, not only in ED, but as in many other systems as well, that this is truly a paracrine effect. In other words, in the lysate, they're antifibrotic, and apoptotic fibers, mitogenic fibers, agents, free radicals, and neurotrophic agents as well. These are the agents that are responsible for improving erectile function. It is truly the lysate, which is extremely important when we talk about curing this disease. So if you look at the effects of mesenchymal cells on stem cells and cavernosal smooth muscle, this is very interesting. 3 amazing things happen. When you give adipose-derived stem cells, you actually preserve the smooth muscle content, you actually prevent fibrosis, and you actually preserve nerve innervation within the cavernosal smooth muscle. To me, this is actually a cure for erectile dysfunction, not just simply treating the symptoms. I present to you the last 3 studies. These are the only 3 studies that we have, only 3 studies in humans that we have for treating men with erectile dysfunction with adipose-derived stem cells. The first one is 7 diabetic men who failed ED medical therapy, average age roughly 70, 15 million human umbilical cord blood stem cells infused into corpora cavernosa. No serious adverse events. 6 of the 7 men regained morning erections by 3 months. The beneficial effects were seen up to 6 months. Very interesting, many of these men also saw significant improvements in diabetes and insulin resistance. The second study, 12 men with ED not responding to medical therapy. These men had a radical prostatectomy as late as 36 months earlier, average age roughly 64. They gave these men 4 different doses of bone marrow-derived stem cells, either 20 million, 200 million, 1 billion, or 2 billion stem cells. Again, no serious adverse events. 75% of the men, 75, reported successful intercourse on medication therapy, basically taking patients who are medication failures and making them responders once again to medication. Now, there was no significant improvement or differences between the 4 doses in recovery of erectile function, but those patients that received the higher 2 doses reported greater erectile hardness scores than those with the lowest 2 doses. And finally, the third study, 17 men with erectile dysfunction not responding to medications. Again, these patients had radical prostatectomy 18 months earlier, median age 69. 1 corporal injection between 8.4 to 37.2 million autologous adipose-derived stem cells. Again, no serious adverse events, but 8 of the 17 men recovered their erectile function. In fact, if you look at those men who were continent, 8 of the 11 men recovered their erectile function. Those that were incontinent did not recover their erectile function, suggesting that maybe continence plays a very important role in the recovery of erectile function. I leave you with one word of caution. You have to realize that we only have 3 studies, and only 3 studies in humans with less than 40 patients. There is no control group, there's no randomization. Further large randomized control trials are desperately needed in this field. At Baylor, we are conducting 2 types of studies. We have a human trial, IRB, only FDA-approved clinical trial. It's a randomized control trial looking at diabetics and patients after radical prostatectomy. These patients are receiving autologous adipose-derived stem cells. 20 of the 30 patients have already completed the study, and we are currently recruiting. We're also doing animal studies, typically looking at a diabetic rat model with autologous adipose-derived stem cells. And the purpose of these studies is to figure out the dosing and the frequency, because today we still do not know the optimal dosing and the frequency to cure this disease. So in summary, ED affects millions of men throughout the world, and the prevalence is on the rise. ED can have a devastating impact on a man's quality of life. Essentially, all available treatment options for ED do not offer a cure and thus allow for this disease to continue to progress. Stem cell therapy offers a potential new and innovative treatment option to help reverse the ED process. And although initial human clinical trials appear promising, more randomized controlled trials are desperately needed in this field. Thank you for your attention.
Thank you for that, Dr. Khera. Just a couple of quick questions. Dosing. Everyone's talked about it, but let me ask you, is more better, or do you start to see a plateau and a diminishing returns?
So, Sanjay, you have to realize that the number of studies we have are very limited, and the studies we have thus far have not shown that the higher doses start causing a diminishing return, although there is some data from other organs that either higher doses may cause a diminishing return. We haven't seen that in ED yet.
And insulin resistance, why do you suppose there was some benefit there?
So you got to remember that the penile tissue is just one, it's a sinus, basically. If you inject something into the penile tissue, it's almost like injecting it intravenously. And so basically we see the same results when you inject intravenous stem cells. You can see the same beneficial effects on diabetes.
Great. You know, we're already out of time, so I wish we could have more time for discussion with everybody. But I think everyone sort of put a note of caution into their presentations as well. We had the Admire trial, we had the Dream trial. These are pretty aspirational names, but it's important to keep in mind that this is still very early, and as we learn more about it, hopefully we'll be able to present more results soon. So thank you very much, and please give a warm round of applause to our panel.